All right, welcome to another deep dive. Today, we're taking a look at something that's pretty critical, I think you'd agree. Cerebrovascular disorders.
Yeah, definitely.
We've got a really interesting mix of stuff to cover, like headaches, which I'm sure we've all had. But then we're also going into transient ischemic attacks.
Right.
And then, of course, the big one, strokes. And we're even going to touch on cerebral aneurysms. So it's kind of a whole spectrum of stuff going on in our brains. And the sources you've given us are really comprehensive.
Yeah, they are.
I mean, they span everything from the basic science to how you actually diagnose and treat these conditions. And the goal here, for me at least, is to try and get a handle on these things without needing to, go to med school for 4 years.
Right. Yeah, definitely. I think that's a great goal.
So what we're going to do is try to pull out the really key info, make it as clear as possible, and hopefully highlight some of the more surprising or even just memorable details.
I like that. And I think what's really fascinating about this topic is that it all comes down to the brain's blood supply. It's like, this incredibly delicate network of vessels. And when things go wrong there, you can see a whole range of problems, from a simple headache to a full-blown stroke.
Yeah, exactly. And that's a great place to start, actually.
Hmm.
Headaches. It's something that almost everybody's experienced at some point, right?
Right.
And our sources actually break them down into three main types: tension headaches, migraines, and then those cluster headaches. So let's start with the one that most people are probably most familiar with: tension headaches.
Sure. Yeah. Tension headaches are, as the name suggests, often related to tension. They're often brought on by prolonged contraction of the muscles in your neck and face. So, think about when you're stressed, hunched over a computer, or doing something that requires a lot of concentration.
Yeah, for sure.
That kind of sustained contraction can really make the pain-sensing nerves in your head, or nociceptors, super sensitive.
Okay, so it's like they're on high alert almost.
Exactly. And when that happens, they release these neurochemicals that your brain picks up as that dull, achy pressure. And it's usually on both sides of the head.
Right. It's that like band of tightness feeling.
Exactly. And the good news is it's usually pretty manageable with things like rest, maybe some over-the-counter pain relievers, and then, of course, trying to manage the underlying stress that's triggering those muscle contractions in the first place.
Yeah, absolutely. Stress management, never a bad thing.
Right. But there are some more severe cases, like if it's chronic or it's just not responding to those basic measures, then, things like counseling, biofeedback, or even in some cases, antidepressants might be recommended.
Right, because it can be a really big problem for some people.
Yeah, definitely.
Now, moving on to migraines, those seem to be a whole different beast altogether. It's not something that you can usually just shake off with an aspirin.
Absolutely. They are in a different category, yeah. Migraines are these recurrent, often very severe headaches that can last for a day or even longer. And what's interesting is that they seem to involve this really complex interplay of factors. Our sources talk about things like changes in the brain's serotonin receptors, and that can lead to those blood vessels dilating. And then, of course, you get the pain. And then there's also fluctuations in hormones. So this is something that we often see, in women, particularly related to their menstrual cycle.
Yeah, it's not just like one thing that triggers it. It's a whole cascade of events.
Exactly. And then on top of that, you have these specific triggers. So certain foods, allergies, even some medications can set off a migraine in somebody who's predisposed.
So it's kind of like a perfect storm situation almost.
Yeah, you could think about it like that. And there's also this genetic component, although we don't totally understand the specific genes involved yet. So there's still a lot to learn. And then another thing about classic migraines, a lot of people will experience what's called an aura.
Right. So that's that kind of pre-headache warning sign that some people get.
Exactly. Yeah, it can involve, changes in mood, difficulty concentrating, really unusual fatigue, and even sometimes trouble sleeping. And all this happens leading up to the actual headache itself.
So it's like your body's trying to tell you something's coming.
Yeah, exactly. And then when the migraine actually hits, the pain is usually described as throbbing or bursting, sometimes with nausea, vomiting, and then even dizziness. And this extreme sensitivity to light and sound.
Yeah, like you just want to be in a dark, quiet room.
Exactly. You just want the world to go away.
Absolutely. And you were mentioning treatments for migraines. It sounds like it goes beyond just taking something for the pain.
Yeah, it does. And obviously, over-the-counter pain relievers can sometimes help with mild migraines. But there are also these prescription medications that are used to both try to prevent migraines from happening and then also to try and stop one that's in progress. So for prevention, you have things like methazorgide and topiramate, and then for stopping a migraine that's already started, you have sumatriptan. But it is important to note that some of these drugs do have warnings, particularly for use during pregnancy.
Right, yeah. So always consult your doctor, of course.
Of course.
Now, we've got one more type of headache to talk about. Cluster headaches. These sound really intense.
They are. They're a different breed, really. Cluster headaches happen in these cyclical patterns. So you'll have a period of weeks or even months where you get multiple attacks every single day, often around the same time of day.
Wow.
And then you might have these short periods of remission where you're headache free. But when they hit, it's brutal. And the exact cause isn't clear yet. But some researchers believe it might be similar to what triggers migraines.
Right, like those blood vessel changes we were talking about.
Exactly. So anything that causes the blood vessels in the brain to dilate, things like alcohol, even certain foods, and even a substance called histamine, might be triggers. And it seems like this dilation puts pressure on the trigeminal nerve, which is a major nerve in the face, and that's what causes that excruciating pain.
Okay, so that throbbing pain that people describe, that's coming from that nerve.
Exactly. And what's even more interesting is that brain scans have shown that there's increased activity in the hypothalamus during these cluster headaches.
Oh, interesting. Now, the hypothalamus, that's involved in regulating our sleep-wake cycles, right?
It is, yeah. So the fact that this area, which is involved in controlling so many of our body's rhythms, is also involved in these headaches, it suggests that there might be this whole other mechanism at play compared to the other types of headaches.
Right. It's not just about the blood vessels themselves, it's also about how the brain is regulating them.
Exactly. And so that opens up this whole avenue for potential treatments, looking at how to target this area of the brain.
Right, very interesting. And you were mentioning the pain itself. I mean, it sounds really debilitating.
It is. The pain is usually on one side of the head, and it often comes with other symptoms like a stuffy or runny nose, tearing of the eye on that same side, and even redness of the eye.
So it's almost like this localized attack on one side of your head.
Yeah, it's this whole constellation of symptoms. And the pain itself is usually described as throbbing, searing, excruciating.
Yeah, not pleasant at all. And it sounds like the treatments for this type are pretty diverse.
Yeah, they are. And because we don't have a clear understanding of the cause, the focus is really on trying to relieve the immediate pain and then preventing future attacks. So some of the medications that are used include things like dihydroergotamine, corticosteroids, certain anticonvulsants, and even beta blockers. And then another thing that can be really helpful is inhaling pure oxygen.
Oh, interesting. Why oxygen?
It seems like it might help to counteract that blood vessel dilation that's thought to be involved in these headaches. So it's almost like you're trying to squeeze those blood vessels back down to their normal size.
Okay, that makes sense. So kind of counteracting the underlying problem.
Yeah, exactly. And then in some really severe cases that don't respond to anything else, a surgical procedure called rhizotomy might be an option.
Wow, so that's a pretty drastic measure.
It is, yeah. It's reserved for the most severe cases.
Yeah.
Now, we've talked about all these different types of headaches. Are there any common diagnostic tools that doctors might use to try to figure out what's going on?
Yeah, that's a good question.
Well, it really depends on, your specific symptoms, your medical history, and what the doctor suspects might be going on. But some of the things they might do include imaging studies like a CT scan or an MRI of the brain. They might do head and neck x-rays in some cases. And then angiography can be really helpful to visualize the blood vessels themselves to see if there's any blockage or any other problem.
Right, so getting a clearer picture of what's actually happening in there.
Exactly.
Okay, let's move on from headaches. And I want to talk about something that our sources really emphasize as something you shouldn't mess around with.
Okay.
And that's transient ischemic attacks, TIAs.
Yeah.
Now, these are often called mini strokes.
Right, and that's a good way to think about them. They're essentially a sudden, brief episode of neurological dysfunction, and it's caused by this temporary interruption of blood flow to part of your brain. But the key word here is temporary.
So it's like the blood supply gets cut off, but then it comes back on its own.
Exactly. It's like a temporary blockage, and then the blood flow is restored. But what's important to understand is that this is often a warning sign, and a very serious one, because the underlying causes are often the same things that can lead to a full-blown stroke.
Okay, so even though it's temporary, it's signaling a bigger problem.
Absolutely. So You're talking about things like atherosclerosis, which is the buildup of plaque in your arteries, arteriosclerosis, which is the hardening of those arteries, as well as heart disease and diabetes. And one of our sources actually mentioned that about a third of people who have a TIA will go on to have a stroke in the future.
Wow. Okay, so that's not something you want to ignore.
Definitely not. It's like your brain is sending you this really important message saying, hey, there's something wrong with the blood supply here. You need to pay attention.
Yeah, that's a pretty clear signal. And what are some of the symptoms that someone might experience during a TIA?
They can be pretty varied, but some common ones include sudden lightheadedness, confusion, maybe difficulty speaking or understanding speech. You might see some vision loss, sometimes double vision. You can get changes in your level of alertness, numbness, or weakness, problems with coordination, and often it affects one side of the body. But what's important to note is that these symptoms usually resolve completely within 24 hours. And they're generally less severe than what you'd see with a full-blown stroke.
Right, but still something to be taken seriously.
Absolutely.
And how do doctors actually go about diagnosing a TIA?
Well, one of the first things they might do is listen to the carotid arteries in your neck with a stethoscope, and they're listening for this whooshing sound called a bruit, which can indicate that there's some turbulent blood flow because of a narrowing in the artery. And then they might do some imaging studies like an ultrasound of the carotid arteries or a carotid arteriogram, which is a special X-ray of those vessels. And then they might do some brain imaging, either with a CT scan or an MRI.
So they're trying to see if there's any blockage or narrowing in the arteries that supply blood to the brain.
Exactly.
Now, our notes also mention some specific things to keep in mind for older adults when it comes to TIAs.
Yes, that's a really important point. Older individuals sometimes might dismiss the symptoms of a TIA, thinking that it's just a normal part of aging. Maybe they just feel a little weak or they get dizzy for a moment and they think, oh, well, that's just because I'm getting older. But that's not necessarily true.
Right, so it's important not to brush it off just because of age.
Exactly. And that's why it's so important for everyone, but especially for older adults, to be aware of these potential warning signs and to report any unusual symptoms to their doctor right away.
Yeah, definitely better to be safe than sorry. And what about the management of TIAs? It sounds like the goal here is really to prevent a future stroke.
You got it. That's the number one priority. And so medical management focuses on aggressively managing the underlying risk factors. So that means controlling high blood pressure, addressing obesity, and absolutely quitting smoking and cutting back on excessive alcohol intake. And then if there are existing heart conditions like atrial fibrillation or recent heart attack, that needs to be managed very carefully.
Right, so it's about addressing all those things that could contribute to a stroke.
Exactly. And that might involve medications like cholesterol-lowering drugs, blood thinners like aspirin, clopidogrel, or warfarin. And for people with diabetes, obviously managing their blood sugar levels is absolutely crucial.
And are there any surgical options when it comes to TIAs?
Yeah, there are. If the TIA is caused by a significant narrowing of the carotid arteries, there are procedures that can be done to try to improve blood flow. And the most common one is called a carotid endarterectomy, where they actually go in and surgically remove the plaque buildup inside the carotid artery. So it's kind of like clearing out a clogged pipe.
Wow, that's pretty amazing.
It is. And then another option is something called percutaneous transluminal angioplasty with stenting, which sounds really complicated.
It is.
But essentially, they use a small balloon to widen the narrowed artery, and then they insert a small mesh tube called a stent to help keep it open.
Okay, so it's like a little scaffold to hold the artery open.
Exactly.
Now, from a nursing perspective, what are some of the key things to focus on when caring for someone who's had a TIA? Maybe someone who's undergone one of these carotid procedures.
Yeah, well, it's really important to get a really detailed history of their symptoms, what happened, when it happened, and then their overall medical background. And then, especially after surgery, frequent neurological checks are absolutely crucial. So we're monitoring for any new signs of weakness, confusion, facial drooping, any speech problems. We're also keeping a close eye on their heart rhythm to make sure there are no irregularities, and then obviously monitoring the surgical site for any signs of infection or other complications.
Right, so really close monitoring, especially in that post-operative period.
Absolutely.
Okay, let's move on now to cerebrovascular accidents, or as most people know them, strokes.
Okay.
Now, this is when that interruption of blood flow that we were talking about with TIAs becomes much more permanent and actually causes lasting damage to the brain.
Right. And so the definition of a stroke is basically that prolonged interruption of blood flow that leads to the death of brain cells. And there are two main categories that our sources highlight. The first one is ischemic stroke, which accounts for the vast majority, about 80% of cases. And then there's hemorrhagic stroke, which is about 20% of cases.
Okay, so ischemic is from a blockage and hemorrhagic is from bleeding.
You got it. So with an ischemic stroke, you have an artery that supplies blood to the brain that gets blocked. And that can happen because of a thrombus, which is basically a blood clot that forms right there in the artery. So like a blockage that forms in your kitchen sink.
Right.
Or it can be caused by an embolus, which is a blood clot, or even some other debris that travels from another part of the body and gets lodged in one of those brain arteries. So that's kind of like, when you have a blockage in your sink and a piece of it breaks off and travels down to cause a new blockage.
Yeah, that makes sense.
Now, hemorrhagic stroke is different. It happens when a blood vessel in the brain actually ruptures. So now you have blood leaking out into the brain tissue itself.
Oh, yeah.
And high blood pressure is often a major contributing factor there. And these types of strokes are more commonly seen in areas like the cerebellum and the brainstem.
Okay, so those are the two main types. Now, our sources also point out that certain heart conditions can really increase someone's risk of stroke.
They do, yeah. So things like atrial fibrillation, which is where the upper chambers of the heart beat irregularly, and then the period following a myocardial infarction or heart attack, both significantly increase the risk of an embolic stroke. And that's because in both of those situations, blood clots can form either in those irregularly beating atria or on the damaged heart tissue, and those clots can then break off and travel to the brain, causing a blockage.
So it's really important to manage those underlying conditions.
Absolutely.
Now, let's talk about symptoms.
Yeah.
What are some of the signs that someone might be having a stroke?
There's a really helpful acronym that's used to remember the key signs. BE, fast.
Be fast.
Yeah. So B stands for balance, so sudden loss of balance or coordination. E is for eyes, so sudden changes in vision in one or both eyes. F is for face, so drooping or weakness on one side of the face. A is for arm, weakness or numbness in one arm. S is for speech, difficulty speaking or understanding speech. And then T is for time, which highlights the importance of calling 911 immediately.
So time is of the essence.
Absolutely. But even beyond those specific signs, there are some other things to look out for. So sudden numbness or weakness on one side of the body, mental confusion, trouble understanding what people are saying, difficulty walking, a severe and sudden headache, nausea and vomiting, and changes in vision.
Okay, so quite a range of potential symptoms.
Yeah.
Now, our sources mentioned hemiplegia, which is paralysis on one side of the body.
Right.
And I was curious, how does that relate to which side of the brain is actually affected by the stroke?
Yeah, that's a really important connection. The brain controls the opposite side of the body. So if you have a stroke on the left side of your brain, it's usually going to affect the right side of your body and vice versa.
Interesting.
But it goes beyond just movement. A left-sided stroke often also leads to problems with language, so aphasia, as well as a tendency towards more cautious behavior, difficulty with learning new things, a shorter attention span, and problems with the right visual field.
So it's not just about the physical paralysis, it's about those cognitive effects as well.
Exactly.
Now, what about a stroke on the right side of the brain? Does that present differently?
It does, yeah. A right hemispheric stroke is more likely to cause problems with spatial awareness and perception, so judging distances, things like that. They might have poor judgment, they might be more impulsive, and they often have problems with their left visual field. And then, of course, they might also experience weakness or paralysis on the left side of the body. And we also use the term hemianopia, which refers to the loss of half of the visual field, and that can happen with strokes on either side of the brain.
Okay, so it really depends on the location of the stroke. And how do you actually go about diagnosing a stroke?
Well, usually the first thing that's done is a CT scan of the brain, because that can quickly tell us whether it's an ischemic stroke or a hemorrhagic stroke. And that's really important for determining the right course of treatment.
Okay.
And then MRI scans can be used to provide even more detailed images of the brain tissue. And then other diagnostic tools might be used depending on the situation, like a transcranial Doppler, ultrasound, to assess blood flow in the brain's arteries. And then things like SPECT and EEG to look at the brain's electrical activity.
Okay.
And then if a subarachnoid hemorrhage is suspected, a lumbar puncture or spinal tap might be done to check the cerebrospinal fluid for blood. And then cerebral angiography can also be used to visualize the blood vessels in the brain and see if there are any blockages or abnormalities.
So it's a whole battery of tests to really figure out what's going on.
It is. It's a very thorough workup.
And the treatment, it sounds like it needs to be really quick, especially for those ischemic strokes.
It does, yeah. For ischemic strokes, time is absolutely of the essence. The goal is to restore blood flow to that affected area of the brain as quickly as possible to minimize damage. And that's where TPA comes in, that tissue plasminogen activator, that's that clot-busting drug.
Right.
But it has a very narrow window of effectiveness, ideally within 3 hours of when the symptoms started. So that's why it's so crucial to recognize the signs of a stroke and get medical attention immediately.
Yeah, that time window is really critical.
It is. Now, for hemorrhagic strokes, the treatment's often different because now you're dealing with bleeding.
Right.
So the focus is on controlling the bleeding and reducing the pressure inside the brain. And sometimes surgery is necessary to actually remove the blood that's accumulated. And then there are procedures like thrombectomy and embolectomy, which can sometimes be used in both types of stroke to physically remove a clot or an embolus from a blocked artery.
Okay, so they're going in and actually removing the blockage.
Exactly. And there's also a lot of research being done on other potential treatments, like using NMDA receptor blockers to try to limit further brain damage, and therapeutic hypothermia, which involves cooling the body down slightly to try to protect the brain.
So it's an area of active research.
Very active. Now, if the stroke is linked to significant carotid artery disease, a carotid endarterectomy, which we talked about earlier, might be performed later down the line. And then if a ruptured aneurysm was the cause of the hemorrhagic stroke, procedures like clipping or coiling the aneurysm might be considered once the patient is stable. But regardless of the type of stroke, intense rehabilitation after the stroke is absolutely crucial.
Right, so helping people regain as much function as possible.
Exactly. And then, of course, strategies to prevent future strokes are really important as well.
So it's a long-term process.
Yeah.
Now, what about nursing care for someone who's had a stroke? What are some of the key things that nurses are focusing on?
Well, nursing care for stroke patients is very comprehensive. One really critical thing is managing any swallowing difficulties to prevent aspiration, which can happen if food or liquid goes down the wrong way and gets into the lungs. So that might involve modifying the consistency of liquids, making them thicker, having suction equipment on hand just in case. And then, because of potential weakness or paralysis, there's often an increased risk for malnutrition. So we might provide small, frequent, and very nutrient-rich meals.
So making sure they're getting enough calories and nutrients.
Exactly. And then because of immobility, there's also an increased risk of skin breakdown, pressure sores, things like that. So regular repositioning and the use of special pressure relieving devices is really important. And then if a patient has communication difficulties, aphasia from the stroke, we'll use various strategies to help them communicate, speaking slowly, using simple language, maybe using picture boards.
So finding ways to work around those challenges.
Yeah, exactly. And then, of course, we're also addressing the emotional and psychological impact of the stroke. So acknowledging their strengths, encouraging as much independence as possible, and just providing support to help them cope with all the changes they're going through.
Right, because it's a huge adjustment.
It is. And there was one thing in your notes that I thought was really important to highlight.
Okay, yeah.
It was about sudden changes in speech in a stroke patient.
Right.
So if someone who's had a stroke, who was maybe able to communicate relatively well, suddenly has a new difficulty with their speech, that could be a sign that the stroke is progressing or that they're having another stroke.
So that's a red flag.
It is. It's a really critical red flag. And the medical team needs to be notified immediately so they can reassess the situation.
Absolutely. Okay, let's move on to our last topic, which is cerebral aneurysms. Now, these sound like weak spots in the brain's blood vessels that can potentially rupture.
Yeah, that's a good way to think about them. So a cerebral aneurysm is basically a bulge or a weakened area in the wall of a blood vessel in the brain. And they're most commonly found at this area called the circle of Willis, which is this network of arteries at the base of the brain.
Okay.
And they can be congenital, meaning you're born with them because of some defect in the blood vessel wall, or they can develop over time because of things like high blood pressure and atherosclerosis.
So kind of like a wearing down of the blood vessel wall.
Exactly.
Now, are there usually any warning signs before a cerebral aneurysm ruptures?
That's the tricky thing. Often there aren't any noticeable symptoms beforehand,
Oh.
but when they do rupture, it's usually very sudden and very dramatic. So the classic presentation is this sudden, excruciating headache that people often describe as the worst headache of their life. And that's usually accompanied by dizziness, nausea, vomiting, and often a rapid loss of consciousness. Now, sometimes, if there's a small leak from the aneurysm before a full-blown rupture, someone might experience symptoms like a stiff neck, a persistent headache, visual disturbances like double vision, and intermittent nausea.
Yeah.
So it's not always silent, But that sudden severe headache is definitely a red flag.
Yeah, that's something you don't want to ignore.
Definitely not.
And how are cerebral aneurysms diagnosed?
Well, one of the main tools is cerebral angiography, which provides very detailed images of the blood vessels in the brain. And then CT scans and MRI scans can also be used to look for aneurysms. And if a rupture is suspected, a lumbar puncture might be done to check for blood in the cerebrospinal fluid. And doctors also use a tool called the Hunt-Hess scale, which is a way to classify the severity of the aneurysm based on the patient's symptoms and their neurological status.
Okay, so a lot of different tools to assess the situation. And what about treatment?
Treatment for an unruptured aneurysm, or even in the initial stages after a rupture, often focuses on these conservative measures.
Okay.
So that means frequent monitoring of vital signs, keeping the patient on strict bed rest to prevent rebleeding, and managing any complications that arise. And then other aspects involve elevating the head of the bed, minimizing light and noise, and then medications like antihypertensive agents to control blood pressure, anticonvulsants to prevent seizures, tranquilizers to keep the patient calm, osmotic diuretics to reduce fluid buildup, and corticosteroids to reduce inflammation.
So it's about controlling those things that could make the situation worse.
Exactly. Now, surgical management is also an option, and the most common procedure is a craniotomy, where the surgeon actually goes in and accesses the brain. And they can either clip the aneurysm, which means they put a small metal clip across the base of the aneurysm to stop blood from flowing into it,
Okay.
or they might do endovascular coiling, where they insert these tiny metal coils through a catheter into the aneurysm to block the blood flow and prevent it from rupturing.
So it's a way to seal it off.
Exactly. And then from a nursing standpoint, there are a few key things that we're constantly monitoring. So we're watching very carefully for any signs of increased intracranial pressure, which is the pressure inside the skull.
Right.
And that means being vigilant for any changes in their level of consciousness, their pupillary reactions, their vital signs, and we want to keep them in a calm and quiet environment.
So minimizing any stimulation.
Exactly. And then seizure precautions are really important. So they might be on anticonvulsant medications. And then pain management is obviously important as well, but we have to be very careful with pain medications, particularly opioids.
Okay, why is that?
Well, opioids, except for codeine in some specific situations, can actually mask important neurological changes. So if a patient's condition is worsening, opioids can make it harder to detect those changes.
So it's a balancing act.
It is.
Okay, wow. We have covered so much ground. This has been a really thorough deep dive into a very complex area. We've gone from headaches, which we all know and love, to these really serious and potentially life-threatening conditions like TIAs, strokes, and cerebral aneurysms. And I feel like I've learned so much from the sources you've provided.
Me too. It's been fascinating.
And one of the things that really stood out to me is just how important it is to take those TIAs seriously. You know, they might seem like just a fleeting thing, but they're often a warning sign of something much more serious to come.
Absolutely. That's something I really hope our listeners take away from this. Don't ignore those symptoms. Get medical attention right away.
Yep, time is brain. We
Yeah.
saw that emphasized over and over again in our notes.
It's true.
And so, looking ahead, I mean, given the complexity of all these conditions and the fact that research is constantly evolving, we even saw some information about artificial intelligence being used to help diagnose strokes more quickly and accurately. What do you see as some of the most promising areas for improving prevention and treatment in the years to come?
That's a great question. I think continued advancements in neuroimaging are going to be really important. Being able to see what's happening inside the brain in even more detail is going to be huge. And then, like you mentioned, AI is going to play an increasingly important role, helping doctors diagnose these conditions faster and more accurately, and also helping to personalize treatment plans. And then, of course, as we continue to unravel the mysteries of the brain, how these conditions actually develop, I think we're going to see the development of even more targeted and effective therapies.
So it's about early detection, better treatments, and ultimately, hopefully, even prevention.
Exactly. It's
Yeah.
a multi-pronged approach.
Well, this has been incredibly enlightening, and we encourage all our listeners to check out the sources that we've discussed for even more in-depth information. Thanks for joining us on this deep dive.
My pleasure. Thanks for having me.